I think it's very important to keep in mind that when we talk about secondary progressive MS, we have a significant unmet need, and that's the patient that really has no appreciable inflammatory activity on the current traditional MRIs or by relapse, by lack of relapses. This is a patient population where we need to have more options, and probably in the future, neuroprotective agents that may potentially be active in other disease states will become important. In the patient that has continued inflammatory activity, and keep in mind the patient may have no inflammatory activity for a year and then later on has again inflammatory activity. So not having inflammatory activity is not a permanent feature. In these patients, it's important to keep in mind that they remain individuals that can be controlled with appropriate intervention with the currently available treatments for MS. Here, very important is the fact that if a patient has previously been on a mode of action, on a certain treatment, and has had breakthrough disease, it becomes very important to try an alternate mode of action in this patient and not to repeat the same mode of action, even if this same mode of action is marketed under a different brand names. So when I think of this, I think of interferons as a class. I think of the glatiramer products as a class. I personally think of the S1Ps as a class. I also think of the anti-CD20s as a class. Obviously, there may be some disagreement from the individual manufacturers or pointing out of differences, of relative differences of the different products. But nevertheless, if a patient has had significant breakthrough disease on, for example, an interferon, it's probably prudent to look to another mode of action to try to control this patient and not switch within the class in an individual. This becomes even more important when we are looking at a patient with secondary progressive MS. And here it's kind of important to keep in mind that the average patients in the United States with multiple sclerosis is in the mid-50s, but another average is also that the average patient with multiple sclerosis is on her fourth treatment for MS. And I purposely used the female pronoun because obviously almost 70% of patients with multiple sclerosis are women. And so that's also something that needs to be kept in the back of one's mind. So we need to recognize one thing, and that is that clinical trials, 2-year clinical trials, give us an information how an agent acts over a relatively short period of time. Emerging larger database, larger communal efforts, derived studies inform on the behavior of agents or approaches to treatment in the overall market. And I think one thing is to actually allow these communal efforts, for example, MS base or registries from Sweden, to really inform also what approaches would be most appropriate for patients. And then to look at that, obviously also with economic considerations in mind, but include in these economic considerations not just the behavior of the next year, but over a longer period of time. And this may be justified because with the fact that many insurers have now commercial product, Medicaid product, Medicare product, also maybe underwriting products for home health care, for nursing home products in different states, that really the traditional sequestration of commercials versus these other approaches is no longer given. It's also very likely that, for example, a pharmacy benefit provider may take care of a patient through many different insurance products that this patient may be stepping through. So I think it would be helpful to start to look at a journey, a patient journey through the longer period of time, and perhaps step back a little bit from the quarterly, at most annual thinking when we are making treatment decisions for patients with a condition that is chronic in the patient and may lead to very significant impact.